Okay, good afternoon, everybody. I'm going to go ahead and get started. My name is Nader Hanna. I'm a surgical oncologist from the University of Maryland. Actually, I've been here before, so this is not the first time I give a grand rounds here, so it's quite an honor and pleasure to come in today. And I'll be talking about improving outcomes in pancreatic cancer. Originally, when this grand round was scheduled, it was last month, which was the Pancreatic Awareness Month, so I thought it would be good to talk about improving outcomes in pancreatic cancer. I have no disclosure. The objectives of the talk are really focused on three aspects of clinical care for patients with pancreatic cancer. Not so for surgeons, but for non-surgical specialties. So I want to discuss the role of neoadjuvant therapy to increase the pool of resected patients. I'm going to talk about why surgery is important. Then talk about identifying risk factors for malignancy and cystic neoplasm of the pancreas, because that's a new entity that's becoming more relevant. We are discovering more cysts in the pancreas, and it's quite challenging to know what to do considering the morbidity of the associated surgery that might be indicated. And then I want to just spend a few minutes to describe recent advances in the management of pancreatic cancer. So quick statistics on why this topic is relevant. So if you look at 2019, pancreatic cancer accounts for approximately 30,000 new cases in men and also 30,000 in women. It is about number 11 in terms of frequency, but it's also, this is the fourth year in a row where the number of cancer in general in women exceeded the number of men. But if you look at the mortality for pancreatic cancer in 2019, it's actually the fourth leading cause of cancer death in the United States, and actually projected to be the second leading cause of cancer deaths by 2020. So by next year, we will see a jump in the incidence of mortality from pancreatic cancer. This is not just related to the United States, but if you look worldwide, you'll find that actually pancreatic cancer is the seventh most common cause of cancer deaths, and it accounts for almost 10 million mortality a year, about 5.4 million in men, and about 4.2 million deaths in women. So it's not just a U.S. issue, it's a general worldwide concern for the high mortality associated with pancreatic cancer. If you look specifically in the United States, you'll find the risk of pancreatic cancer increases with age, and approximately about 55-60% of patients are going to be age 65 and older. And in fact, 9 out of 10 patients with pancreatic cancer are going to be 55 years old, and 7 out of 10 patients will be actually age 65 or older. And if you look at some of the disparities, you'll find that African Americans tend to have increased rate, higher risk for pancreatic cancer, not only incidence, but also have worse mortality than most other races. So there is a lot of work to be done for disparities. So why pancreatic cancer is called neglected silent killer? First of all, unlike, for example, colon cancer, we don't have a lot of information about the genetic and molecular events. There is really no precursor screening or even screening test that we can do, unlike mammography for breast cancer or colonoscopy for colon cancer or pap smear for cervical cancer. And really precursor lesions are really limited to IPMN, and that's another category of discussion. There's a lot of misconception and lack of knowledge about the treatment. It has a bad rap that most patients die with pancreatic cancer. While that might be true in the old days, I'm going to show you the recent data and numbers and prove that this is not the case, and certain patients can benefit from multimodality treatment. And then obviously there's the nihilistic attitude to pancreatic cancer. You have pancreatic cancer, might as well just go Hawaii and enjoy a nice vacation. So this, unfortunately, even today, this seems to be still prevalent in some areas of the U.S. If you look at the survival by stage, you'll find that obviously as the stage progresses from stage 1 to stage 4, the 5-year survival does decrease. But really, if you look at for stage 1, 2, and 3, where there's a role for therapy, and the pointer is not working, but anyway. So if you look at 5-year survival, you quite a distinct difference between stage 1, which is the blue bar, and stage 2 and stage 3. So there's quite a drop in survival at 5 years, even for multimodality treatment for patients. So as the patient becomes node positive, the risk of lower 5-year survival becomes evident. Now, if you look at the role of surgery, because this is the main issue with pancreatic cancer, so this is data from 2006, and this is the 6-year survival data. And let me see if I can get yeah, okay, here you go. So this is the median survival. This is patient who had surgery. This is patient who did not have surgery as part of the treatment plan. And then you look at the 5-year survival. Again, patient who had surgery and no surgery. For localized disease, patient who had surgery, median survival was 17 months compared to 8 months. 5-year survival, 25 to 8%. Patient who had regional disease, who had surgery, again, median survival, of course, is less than localized disease, but 11 versus 7. And the 5-year survival, 10% to 3%. What you actually notice that any patient who had surgery, regardless of whether they are localized or regional disease, what happened, you'll find that the median survival is actually better, but also look at the 5-year survival. When you see the 5-year survival for patient who had surgery for localized or regional disease, almost triples. So clearly, one of the most important aspects of treating localized and regional disease, what's the most important prognostic factor, is really surgical resection. So it's by far benefit anything else in the treatment algorithm for pancreatic cancer. If you get the patient to have an operation, their 5-year survival for regional and localized disease almost triples compared to those who do not get surgery as part of the treatment plan. And in fact, if you look at our national failure to operate on early stage pancreatic cancer. So if you look at, this is from 1995 to 2004, this is the patient who have got no treatment. You can see, yes, the number back in 1995 was almost 55%, never get any treatment. But, while it did improve, but still almost 43, 44% of patients do not get any treatment, even though they're early stage pancreatic cancer. The percentage of patients who had no surgical treatment, somehow it's about stable, maybe decreased, but there's a good trend, but not enough. The solid line, so there has been gradual increase in the pool of patients who were referred to surgery, even though these are early pancreatic cancer. So they looked, this is again, if you look at the patient, actually this is a study that actually was published back in 2007. Well, they looked at almost 10,000 patients with early stage pancreatic cancer. And they found that only 28% underwent surgery. So less than a third who had surgery. Almost 70% had no surgery. This is, again, early stage pancreatic cancer where surgery would have been very appropriate. Almost 27% from the total underwent pancreatectomy. It was found to be unresectable in about 1% of cases. The majority of patients who had no surgery, and they looked at the reason why this patient did not have an operation. They found that by far, almost 40% of patients were not offered any surgical recommendation whatsoever. About 4% refused an operation, and then because of comorbid condition or advanced stage, it was about 15%, and unknown about 13.5%. So this is really the major problem here. This is a patient who would have benefit from surgery. 40% of those patients were not even offered discussion about an operation. So I think it is a little embarrassing. And when you look at the survival of those patients, so this is the patient here on top who were offered no surgery, percentage-wise. And you can see that underwent surgery. Yes, the number of patients over the year has increased. And this is the number of patients who have declined, offered with no decline. So point is, in terms of surgical resection, there is a significant role. Now, what they did then, they looked at the survival of those patients. So if you look at the survival of a patient who has pancreatectomy for stage 1, you can see that the 5-year survival was almost about 24, 25%. For patients who were not offered surgery and who were stage 1, guess what? Their 5-year survival was no different from patients who presented with stage 3 or stage 4 disease. So clearly, a simple modality that was not incorporated as in the treatment algorithm for those patients contributed to their demise and actually inferior survivorship. So this is really where the discussion is going to focus on what is the role of surgery. So the whole thing about pancreatic cancer and surgery is about the definition of anatomic resectability. And so when we talk about pancreatic cancer, we talk about resectable pancreatic cancer. This is tumor, as you can see here, clearly defined to the pancreas. And it's always the description in relation to the blood vessels. So resectable tumors in general, this is a tumor. They are far from the blood vessels. The vessels are free. And obviously, there is no metastatic disease that include non-regional lymph nodes. So if the patient has what looks like resectable pancreatic cancer but has, for example, para-aortic nodes, that's metastatic disease, so this patient are non-resectable. So there's the definition of resectable disease. Borderline resectable, there is impingement on the adjacent vessels, and you have the superior mesenteric vein and the portal vein, where the tumor can actually, what it does, you can see now coming in contact with the superior mesenteric vein or superior mesenteric artery, but less than 50% of the circumference, or 180 degrees. This is what we define as borderline resectable disease. And then the locally advanced tumor, obviously these are the tumor where the tumor actually surrounds the superior mesenteric vein or the artery greater than 180% degree or more than 50% of the diameter, or there is a venous thrombosis of the superior mesenteric vein or portal vein, or the vein is not reconstructible for greater than 2 centimeters lengthwise or 1 centimeter in most articles that will show that. So this is just a quick definition, but let's look at the role of neoadjuvant. So obviously for a patient with resectable disease, surgery should be offered and indicated. There's no reason not to do that unless the patient comorbid condition prohibits doing that or the patient declines surgery. This is a study that actually was published in 2010. They looked at the role of preoperative neoadjuvant therapy. And what they did, they looked at the whole group and they divided the patients. This was almost about 4,400 patients from multiple studies. And they looked at group 1, which is patients who have borderline resectable disease or borderline resectable. And group 2 included the locally advanced or unresectable disease. And what they looked at, just the definition quickly, this is the patient who had complete response by imaging. This patient who had partial response. These are stable disease, and these are the patients who progressed while getting the adjuvant therapy. And if you look at the percent patients who were resected, and this is the rate of R0 resection, the total group was about 50%. Obviously, group 1 who were resectable or borderline resectable, the resection rate was almost 74%. And in group 2, which are the locally advanced or unresectable, about 1/3 of patients actually came to surgery. And the negative margin rate is obviously not too far difference. The point is, neoadjuvant therapy does provide the benefit, and I'll talk about that. So about 1/3 of patients who were deemed to be locally advanced or unresectable with neoadjuvant therapy would come to surgery. And if you look at the morbidity, this is the morbidity and the mortality. The morbidity is no different. Yes, the mortality is a little bit higher on the advanced group because it obviously involves vein resection and reconstruction. So it does add a little bit to the mortality, but overall, this patient, about 1/3 of this patient actually can have surgery, with 2/3 of those patients having negative margins. So that's quite an impact of the neoadjuvant therapy. As I said, 1 out of 5 patients will progress during the disease. Now, this is looking at the survival. So we're going to look backwards. We're going to look at the slides from bottom up. So this is the median survival. And the highlighted ones where the patient have survived the longest, okay? And what do you find between these common 3 groups of patients who had the best survival is resection. And so if patient is resectable, the median survival is about 20 to 23.6 months. If they get neoadjuvant therapy, look at neoadjuvant therapy. Okay, still didn't add much. But for the locally advanced and unresectable, remember, about 1/3 get into resection, and look at the survival. Is no much difference than the original patient who had resectable disease, and their 5-year survival, and the median survival was no different. So clearly, we've made some progress on those patients who are considered locally advanced or unresectable. 1/3 is going to come to resection, and 2/3 of those patients will have negative margin. About 20 to 30% of those patients will progress and will not be surgical candidate. So if you look at the difference in the meta-analysis, looked at modified FOLFIRINOX, which is a tough regimen to give to patients. But anyway, when you give this patient and look at the progression-free survival between patients who underwent resection versus no resection, you can see the quite significant difference in survival and the progression-free survival. So for resected patient was 18 months versus 8 months, and the p-value was quite significant. And so obviously the conclusion that you're doing neoadjuvant therapy and patients who are locally advanced, borderline or unresectable, does add to their improved survival and progression-free survival. So this finding led to locally advanced pancreatic cancer trial looking at the role of chemoradiation. Okay, so obviously our radiation oncology colleagues have interest in advancing science as well, so it was in the role of radiation therapy. So there's the Lab 07, where they looked at induction chemotherapy followed by randomization to either continuation of chemotherapy or chemoradiation. So everybody here got induction chemotherapy, and then 269 patients from the original 442 were randomized, and about half of those got chemo alone and half get chemoradiation. And they looked at the outcome. So if you look at the median overall survival was no different between the two groups, and the median progression-free survival was no difference between the two groups. So the conclusion of the study was the addition of chemoradiation after induction chemotherapy did not improve the survival. So that really begs the question, is who gets chemoradiation after induction chemotherapy? Do we do it? Yes, we do it, but on certain patients with different criteria. So a patient gets an induction chemotherapy. If they have evidence of local progression after induction chemo, we would give them chemoradiation, try to bring the disease stage back down to allow them to undergo surgery. If the patient is having bleeding or poorly controlled pain or local obstructive symptoms, mostly related to gastric outlet obstruction, this patient then can get neoadjuvant chemoradiation, trying to add additional downstaging of this tumor to allow them to come back to surgery. So for patient judged to be resectable, what is the message here? Neoadjuvant therapy provided no survival benefit versus adjuvant therapy. Okay, so resectable disease, adjuvant therapy does not really provide benefit in most patients. For patient judged to be unresectable, what's the message? 1/3 of patients will become very resectable and should undergo surgery. Remember, 2/3 will have negative margin, and this patient will have very similar survival to those patients who undergone initial surgical resection. But what is the challenge? For the patient who are judged to be resectable, the challenge is identifying the truly borderline resectable disease and patients who have unfavorable biology. So do we do neoadjuvant therapy in resectable disease? Yes, and I'm going to show you those group of patients to do. For patients who are judged to be unresectable, the challenge here is identifying bad tumor biology. And this is where the role of molecular genetics and subtyping and gene sequencing can apply a role, and I'm going to show you some of the proposed algorithm and how to use these markers in gene sequencing to identify patients who have locally advanced disease who may not benefit from surgical resection. And this is really what we call window of opportunity trials. These are the patients who need to be randomized in clinical trial. So for resectable disease, resection followed by adjuvant therapy, and usually the two protocols of FOLFIRINOX, and usually for ECOG 0 to 1, because this is a tough chemotherapy regimen, or gemcitabine plus capecitabine. These are the standard treatment, gem plus capecitabine. You would consider neoadjuvant chemotherapy for resectable. This is the group that I would recommend that giving neoadjuvant chemotherapy is for high-risk patient. Who are these high-risk patients? Patient with large primary tumor or a large node of disease, even though they appear resectable. Excessive weight loss, more than 40 pounds. If the patient comes and tells you they lost 40 pounds or more. and patients who have extreme pain that's not controlled by the standard dose of narcotics, and dose was markedly elevated CA19 9 greater than 200. These are the patients who we would consider giving neoadjuvant chemotherapy, even though in the imaging study they are resectable disease. For a patient with borderline locally advanced disease, we always give neoadjuvant chemotherapy. Now, the choice of regimen, there is very limited evidence, so we don't have great evidence to say which regimen is better than the other. But there are generally two regimens that we use. One is the FOLFIRINOX or modified FOLFIRINOX, but the patient has to have an ECOG 0 to 1 because this is a tough regimen to handle. Patient with age 75 also don't do too well with that regimen. The other alternative is the GEM plus paclitaxel. This would be the standard treatment. Now, the new things in pancreatic cancer, I'm going to talk about in the next slide, is genetic testing. So patients who who test positive for genetic mutations, the standard treatment will be either FOLFIRINOX or gemcitabine plus cisplatin. So that's the difference, and I'm going to talk now about some of the recent advances for pancreatic cancer. The first one is now becoming a standard of care. If you look at the NCCN guidelines, the new version that's just been put out, everybody with pancreatic cancer, regardless of age, need to be offered genetic testing. So it's not a choice anymore. And the genetic testing is germline mutation, and we test for 3 specific mutations, the BRCA1 and BRCA2, which is obviously everybody knows for breast cancer, and the BALB2. It can be done from the blood or the saliva. As I said, everyone with newly diagnosed pancreatic cancer should have the test because it's an inherited mutation, and based on this mutation, again, this is the patient who will receive platinum-based chemotherapy, which is the GEM plus, so FOLFIRINOX plus cisplatin, or GEM plus cisplatin. Now, the good news is this test is actually free of charge. There's a company that offered this test free of charge, not only free of charge for the patients, but if the patient is tested positive, okay, they will offer free genetic counseling to the patient and the family for 90 days from the result of the test, with absolutely no cost to patient. So any patient who has pancreatic cancer, there should be offered free testing, and there's no charge for that. And it does change the chemotherapy if they're positive. The second type of tumor testing, the second type of genetic testing that we should consider for a patient with pancreatic cancer is the tumor testing for MSI and the MMR gene. This is a required biopsy from the tumor, and this actually helps plan treatment or actually predict response. So this is really becoming the standard, even in a community hospital, community setting. This should be done for patients with pancreatic cancer. The new drugs in the market, everybody, of course, have heard about it, is the targeted therapy. This is mostly not in the neoadjuvant setting, but these are for patients with metastatic disease who are not a candidate for surgery. Besides targeted therapy, immunotherapy, or biological therapy, Keytruda is being the most known for one, but this is only for patients who have PD-L1. This is an inhibitor for those patients, and specifically for pancreatic cancer patients that are MSI high. Now, I didn't go into details about molecular markers and subtyping of pancreatic cancer, but really what most people are looking at now is looking in combination not only of anatomical resectability of pancreatic cancer, but looking more at the diagnostic and as well as the prognostic and predictive biomarkers. So, in the best scenario, how would we treat patients with pancreatic cancer? So, obviously, diagnostic would include blood testing, the detection of pancreatic adenocarcinoma, but then you want to look at circulating mutant KRAS, serum metabolites, or serum antigen, and you will identify patient who has aggressive molecular feature. Okay, this is patient who have resectable disease. Okay, so I'm going beyond just anatomical classification. So if the patient have no aggressive molecular feature, they move into resection, and then they get adjuvant chemo plus or minus radiation. If they have aggressive molecular feature, now we need to look at the pattern of the molecular profiling. Is that predictive of locally advanced recurrence or local recurrence or of metastatic disease? And if it's local recurrence, then we would give them neoadjuvant chemo plus XRT because we know chemoradiation therapy is effective in local control. And a perfect example of that is gastric cancer, the McDonald trial. If they have risk of distant metastasis based on the molecular profiling, then we give them neoadjuvant chemo only because radiation will provide no benefit. So you do that, you obviously will do surgical resection, but then you repeat the molecular profiling so you can decide on the adjuvant treatment. And again, look at the BRCA mutation, look at the HER1 gene signature, and based on that, you can actually choose the type of chemotherapy that you would give the patient in an adjuvant setting. So this is where we're currently going with pancreatic cancer. Obviously, this is not standard of care. Most of this is going to be done on clinical trial. The issue here is that you need a lot of patients. So it's not going to be done in a single institution unless you're really, really one of those centers who say, see hundreds and hundreds of pancreatic cancer patients a year. But this is actually real happening, and hopefully we can see some restratification of how patients are being treated with pancreatic cancer. There was a lot of buzz recently, not recently, several years ago, about the use of metformin in pancreatic cancer and whether it's actually improved survival. So really this information came from a retrospective review of almost 1,400 patients with pancreatic cancer and diabetes from the Mayo Clinic. And they looked at the patient who used no metformin. The median survival was 8.1 months. Who was started on metformin within 30 days or more than 30 days, and you find that the median survival showed some trend that it was, better. But really, we're not sure, so it's not recommended that you put patient metformin just simply because you think this is going to improve the survival. I think there are much better ways to improve survival. The most important one is obviously increasing the pool of patients who are coming to surgical resection. So this is a kind of just a quick, brief soundbite about pancreatic adenocarcinoma. I want to talk a little bit more now about cystic neoplasm of the pancreas because this is actually where we can also improve outcomes significantly. There are 4 types of cystic neoplasm of the pancreas: the serous, the mucinous, the IPMN, and the solid. So the 1 and 4, the top and the bottom are relatively benign. Risk of malignancy is very, very small if it exists. So I'm going to focus on the mucinous cystic neoplasm and the intraductal papillary mucinous neoplasm, or known as the IPMN. Why is that? Because the prevalence is about 2 to 14% on the imaging study. Now everybody comes to the emergency room, gets a CAT scan. If you're complaining of headache, somehow you manage to get an abdominal CT scan, and here you go, you see a pancreatic mass, a cystic mass, and you don't know what to do with it. The biological behavior can range from being benign to aggressive malignancy. And actually, those malignancy of all pancreatic cancer, 10 to 15% are reported to occur on some form of cystic neoplasm of the pancreas, or IPMN. And the problem is this patient requires lifelong screening, is often needed. So the challenge here is identifying the malignant potential of the cystic neoplasm, because if we can prevent progression, we can define the extent of surgical resection and also minimize the need of lifelong screening and related costs, because this is obviously healthcare related costs are a significant issue. So where do we know the information about risk stratification? It comes from a retrospective review of almost 1,800 patients with pancreatic cystic neoplasm during a 5-year period. And what they found from this study, that the overall age and gender adjusted risk for pancreatic malignancy was actually 35 times higher than the general population. So if you have a cystic neoplasm, your risk of cancer jumps quite significantly. And based on the finding and stratification, they stratified patient into a low risk, an intermediate, and high risk based on size, the size of pancreatic ductal dilatation, septation and calcification, and the annual growth rate of this cystic lesion. So let's just look in more detail. How we diagnose them, obviously I'm not going to go into detail about that, but just to point out that most patients are diagnosed on a CAT scan. The role of the CAT scan is to rule out metastatic disease. But MRI, MRCP is actually is the preferable imaging study once you have a patient diagnosed with incidental finding of a pancreatic cystic neoplasm. It's high contrast imaging and provides more detail about the details of the cyst wall, the septation, mural thickening, or solid component. So any patient who has cystic neoplasm, CAT scan is not enough. Most of us would get an MRI or MRCP to identify really the features that suggest this is a worrisome for malignancy or not. So for mucinous, imaging for mucinous cystic neoplasm, what are you looking for? What are the suspicious feature? The finding associated with malignant transformation and a mucinous cystic neoplasm are 4 established criteria. There's no question about it. So a cyst greater than 50 millimeter, equal or greater than 5 centimeter. This is a finding are associated with high risk of malignancy. A thickened or regular cyst wall, an inherent solid component or mass within the cyst, or possible calcification of the cyst wall. These are mucinous cystic neoplasm, or a very high risk of having malignancy. This patient would require surgical resection. There's no dispute about this high risk category feature. If you look at the IPMN, there is 2 types of IPMN. There's the main duct and the branch side branch IPMN. And IPMN is defined, used to be defined in 2006 by dilatation of the main pancreatic duct greater than a centimeter, or without other causes of obstruction. Okay, there's no proximal obstruction that would cause the dilatation of the pancreatic duct. However, in 2012, this was redefined as a segmental or diffuse dilatation of the main pancreatic duct of greater than 5 millimeter. And this is based on the preoperative imaging and not the pathological feature, because sometimes the pathology would show that the duct actually was can be smaller or larger than what the imaging studied. So this is based on the preoperative imaging. And so patients who have a duct size, mean pancreatic duct that's measured between 5 and 9 millimeter, this is what we call worrisome finding or feature. Patient with a high risk are those who are 10 millimeter or above. And why is that important? Because if you look at some published study looking at particular size of pancreatic duct dilatation and risk of malignancy, you can see that as the duct size increases, the risk of having malignancy, main duct IPMN malignancy goes very high. And it's above 50% once the duct goes above almost 2 centimeter. So 1 centimeter is the cutoff for a high risk feature. This is for the branch duct IPMN. Cyst size and risk of high-grade dysplasia or invasive carcinoma. Again, look at the cyst size greater than 30 centimeter. You can see percentage of patients with high-grade dysplasia or invasive carcinoma. Again, goes quite high, greater than patient who have side branch IPMN greater than 30 millimeter. Again, this is all retrospective study because you're not randomized patient to follow up to see if they have cancer or not. Because once you have pancreatic cancer, guess what? Your mortality, even for stage 1, 5 years, is 24%. So no way there will be a randomized trial comparing this patient to observation versus surgery, right? So most of this data is retrospective. So when you do imaging for cystic neoplasm of the pancreas, when do you do biopsy? Does everybody with cystic lesion of the cystic neoplasm of the pancreas need a biopsy? No. Because doing a biopsy still can have a risk, whether you're doing EUS, FNA, or you do it, CT-guided imaging study, still there's a risk. So we only consider biopsy for a certain group of patients. Number 1, if the cyst lesion is greater than 1.5 centimeter in size, or lesion with worrisome feature. Okay, this includes cyst component within the cyst, mean pancreatic duct, again greater than 5 millimeter, symptoms related to the cyst, growth rate greater than 5 millimeter than year. So if you have a patient who comes in was 1.5 centimeter and you repeat the imaging study in less than a year and the growth rate is greater than 5 millimeter, this is a worrisome feature that requires EUS and a biopsy of the lesion. A patient who have family history of pancreatic cancer who developed cystic neoplasm of the pancreas, again, these are the group of patients who would need EUS and a FNA for this lesion because they have a high risk of malignancy. So when you do the biopsy, what do? It's very hard to biopsy the cyst wall itself, right? Because it's very thin. So what we actually do when they do the biopsy, they aspirate the cyst content, okay? And the cyst cytology has to have mucin. So they have to have mucin-containing cells. That's how you make a diagnosis of mucinous cystic neoplasm or IPMN. It's diagnostic, but sensitivity is limited because most of the time the cytology scans number of cells, so it's sometimes very difficult. There's no cells to examine. Okay, so cytology for detecting mucinous lesion sensitivity is only 35%, but specificity is about above 80%. Okay, so the really key two features you're looking for, the presence of high-grade cytology is the only statistical predictor of malignancy. Okay, so you hear about MLA's level, CEA level, CA19.9, CA15.5, you name it. The only predictor of malignancy, and this aspirate cytology, is the presence of high-grade cytology. And if there's a pathologist in the audience right here, there's a specific definition for what's called high-grade cytology. They look at the nuclear chromatin, the size, and a couple of other features. Again, it's well established and well published in what is high-grade cytology. The key next message here is the absence of atypical or malignant cells does not exclude the presence of malignancy. Okay, so there's really no good test yet. So what the next step was is to look at actually tumor markers in the cyst fluid. So the question was, does tumor marker help us really stratify patients to find out patients who are at a high risk or having malignancy or harbor malignancy? So the tumor markers we study, not every hospital does this, but the minimum is CEA and CA19.9. I think most places would do that. Other places would do the CE72-4 and the CE15-3 and the CE125. And the CE by far is the most studied and accurate tumor marker for diagnosing a mucinous tumor, neoplasm. I did not say malignant mucinous neoplasm, okay? What a high level of CEA and the cutoff level is 192 to 200, the presence of this higher level of CEA tells you it is indeed a mucinous tumor, but it does not tell you it's malignant or not. And a low level of CEA also does not exclude that mucinous cyst. So you have to be careful about the interpretation. So you have really to combine the imaging study findings, the EUS, and the cytology. And again, the key message is there is no direct correlation of CEA concentration with malignancy, because there is a misconception that if you have a high CEA level, this is malignant. No, it is not. A high CEA level just proves to you that this is indeed a mucinous neoplasm of the pancreas. So if you look at the different cyst fluid analysis tumor markers versus comparing serous cystadenoma versus mucinous cystic neoplasm and IPMN, it does help you differentiate if there's a question about the serous cystadenoma versus other more concerning type of cystic neoplasm of the pancreas. So beyond the tumor markers, looking at some mutations. So people looked at the KRAS mutation, the GNAS, and the RNF43, the VHL, and others. And the presence of these profile markers does support a neoplastic mucinous cyst, but not necessarily malignant. Okay? It does not distinguish IPMN from mucinous cystic neoplasm. It cannot tell you the presence. Okay, the GNAS does support IPMN over mucinous cystic neoplasm, and again, it does not correlate with the grade. So even the presence of these diagnostic markers does not tell you it's malignant. It just tells you whether it is IPMN or cystic neoplasm, or it is indeed a mucinous neoplasm of the pancreas. Again, does not correlate with malignancy. There are some tumor markers who, when patient has malignancy, are of prognostic value. This is the TP53 and the PIK3CA and the P10. These are more prognostic when you have a diagnosis of malignancy in cystic neoplasm. So what are the indications of surgery of IPMN? So this is the most recent recommendation that was published last year. So this is different from the ones that was published about 4 or 5 years ago. So please, this is the new recommendation. So there is absolute indication for patients who have IPMN. This is the most recent recommendation. If they have positive cytology for malignancy or high-grade dysplasia, and there is specific definition characteristic that the pathologists follow for diagnosis of high-grade dysplasia. Solid mass, patient have jaundice related to the tumor. Enhancing mural nodule that is 5 or greater millimeter in diameter, or mean pancreatic duct dilatation equal or greater than 10 millimeter. This is absolutely any patient of those who did not have surgery and subsequently have cancer and not being treated, you are not following the standard of care. The relative indication. So relative indication, you need to consider patient comorbid condition, family history, a lot of other things that play into decision making. But this is the relative indication. Patient who have IPMN causing acute pancreatitis, increased level of serum CA19-9, especially if it's greater than 200, cyst diameter greater or equal than 40 millimeter. So that's a different from the prior recommendation because the prior recommendation was 30 millimeter. Now we've opted up to 40 millimeter. Remember, this is a relative indication. Mean pancreatic ductal dilatation between 5 to 9.9 millimeter, and growth rate greater or equal than 5 millimeter per year when you do our annual surveillance for this patient. Enhancing mural nodule less than 5 millimeter in diameter, but more importantly now is a new onset of diabetes associated with this mucinous cystic neoplasm. In general, new onset diabetes in age 65 and older, you really should consider scanning this patient with abdominal CT scan to rule out pancreatic mass or pancreatic adenocarcinoma. So this is some of the relative indication for surgery in IPMN, the new onset of diabetes in a patient with IPMN. This is actually also the updated algorithm based on the European evidence-based guidelines on cystic neoplasm of the pancreas. This is now not IPMN, this is the cystic neoplasm of the pancreas. And I don't know if you can see it here, but there is no indication of the surgery on the first year of diagnosis. But what you need to do is this is actually the benefit of this algorithm is it tells you what kind of follow-up you need to do for this patient. So if you determine you suspect IPMN, but there is no indication of surgery, no relative or absolute indication, what do you do? A clinical evaluation, serum E19-9, MRI, and ultrasound every 6 months until you do it twice after the first year. Then you move into clinical evaluation, serum CA19-9, MRI, and or EUS annually. So once you made the diagnosis, the first time you made a diagnosis of mucinous cystic neoplasm, you do it every 6 months for a year, and then annual after that. You'll obviously do clinical evaluation to rule out obstructive jaundice, pancreatitis, things like that, and you'll follow up with an MRI, preferably, or endoscopic ultrasound, depending on the expertise of your gastroenterologist. If the patient has relative indication for surgery, if the patient with significant comorbid condition or short life expectancy, okay, and only one relative indication for surgery, you would do surveillance every 6 months. If the patient was at significant comorbidity and one or more relative indication for surgery, you would definitely consider, for this patient, it's quite reasonable to talk about surgery. Patient who has absolute indication for surgery should undergo surgery. But the key, the new recommendation is this patient need lifelong surveillance for additional lesions that might appear in the pancreas. Patient unfit for surgery, save money because you're not going to operate in them ever. Don't do any follow-up. It's really costly with no quite benefit to the patient. So this is some of the recent advances for cyst fluid analysis as the next gene sequencing. This is some of the information. Right now it's not for the mainstream practice, but this is what the future would hold is the next gene sequencing, trying to identify patients who are truly at high risk for malignant transformation or who should undergo surgery. And I think I'll stop right here. I'll be happy to take any question. And thanks for the kind invitation to be here with you today. Thank you very much. So are all guys now expert in pancreatic cancer. So quick message, genetic testing should be offered to all patients with pancreatic adenocarcinoma. It's free and should be considered. Thank you.